Certainly from the human perspective, we know that glucose toxicity starts with a blood sugar of 200. So once your blood sugar is over 200, you are poisoning certain cells. Ironically, particularly vulnerable to being poisoned are the beta cells. So every day a cat sits with a blood sugar over 200, we know that they are actually damaging their beta cells.
Hello, Vetfolio Voice family. Welcome back. I am thrilled to bring you this episode, sponsored by Boehringer Ingelheim Animal Health, because this episode features Dr. Audrey Cook, who I absolutely love having on the podcast. I'm a bit of an endocrinology nerd, and I love getting to pick Dr. Cook's brain about different disease processes. And in this case, we jumped into feline diabetes and decision making when presented with a new diabetic, since the availability of oral SGLT-2 inhibitors like Cinvelgo or vilogliflozin oral solution have given us multiple treatment options to consider. We talked about the types of patients who are the best candidates for treatment with an SGLT2 inhibitor versus those who are better candidates for insulin therapy. We covered diagnosis and recommendations around diabetic ketoacidosis and parameters for monitoring ketones when starting a patient on an SGLT2 inhibitor. And of course, we covered the possibility, however rare, of euglycemic DKA in a patient treated with Cinvelgo. Perhaps even more importantly, however, we dove into some of those shades of gray around treatment of feline diabetes. Of course, the possibility of treatment with an oral medication is very appealing to cat owners, but what do we do when we have an owner who's pushing for an SGLT2 inhibitor and a patient who may be a less than ideal candidate for that drug? Or what do we do in a patient who shows mild ketone elevations but is clinically healthy on an SGLT2 inhibitor? And those are just a couple of the examples of just the more nuanced topics that we covered. And of course, Dr. Cook did an excellent job illustrating how to think through these cases in a very practical way that felt usable in general practice, where we see many of these cases and are all too aware that treating cats is rarely ever straightforward. If you don't know her already, let me introduce Audrey Cook and we'll talk feline diabetes. Dr. Audrey Cook is a graduate of the University of Edinburgh in Scotland. She completed her internship at North Carolina State and her residency in small animal internal medicine at UC Davis. Dr. Cook is a diplomate of both the American and European colleges of veterinary internal medicine and is also recognized as a specialist in feline practice by the American Board of Veterinary Practitioners. After a decade in private referral practice, Dr. Cook joined the faculty at Texas A&M. She's now a professor of small animal internal medicine and is primarily assigned to the interventional radiology and endoscopy service. I know there are so many questions around navigating the use of these medications and how to correctly incorporate them when we're treating cats with diabetes. So let's go ahead and jump in and hopefully we can answer some of those questions.
Nutrition is the cornerstone of our patients' health and happiness. The veterinary healthcare team should be the ultimate source for top-notch pet nutrition info. When clients see how the right diet helps their pets stay healthy and happy, they visit us more often. Remember, good nutrition is essential. It's smart business and great medicine. Enroll in the NAVC Pet Nutrition Coach certification today on vetfolio.com.
Well, for this episode, super excited to be joined again by Dr. Audrey Cook. I always love when we can talk because I learned so much, and we're tackling what I think is a particularly difficult endocrine disease, and that's diabetes in cats. We're having all kinds of new options and things like that. So, Dr. Cook, thank you so much for joining me and reviewing all of this with us.
Oh, I'm happy to be here, Cassie.
Yes, so happy to have you. I know one of the directions we wanted to take this conversation is decision making when it comes to diabetics. And that can be complicated just in and of itself with, insulin and do we have a healthy diabetic and DKA and all this stuff. But now, of course, we have SGLT2 inhibitors like Cinvelgo on the market, and that presents this whole new layer of decision making. So with that in mind, when we're presented with a new diabetic, what sorts of criteria should we be keeping in mind when we're deciding on a treatment plan? I guess what would make us err more towards insulin versus an SGLT2 inhibitor and vice versa?
That is a really good question. I mean, traditionally, we didn't have a lot of decisions to make apart from which insulin you were going to pick, but now we have this whole new option with the SGLT2 inhibitors. I think my approach when faced with a brand new diabetic would be to kind of default to the SGLT2 inhibitors, but then I would think about reasons why that wasn't a good choice for this cat. And the reason I would tend to default to the SGLT2 inhibitors is ease of administration. This is not some teeny tiny dose given with a terrifying needle. So that's has a huge impact. We're talking about with the Synvelgo and a very flavorful oral liquid that can be put directly into the mouth or placed on the food once a day, but the timing doesn't have to be too precise. The other huge advantage to the SGLT2 inhibitors is essentially we're not going to end up with a cat whose blood sugar plummets and who has significant clinical compromise. And so that to me is another absolutely massive advantage. So my default position would be this is my first thought is, can we get this cat onto an SGLT2 inhibitor? But there are some patients where that is not going to be a good idea. And probably the very first criteria we'd look at is where are they at as far as their ketone levels. And so we're strongly recommending that vets get a hold of a handheld ketone meter. They are cheap, they're very easy to use, they're just like a glucometer that we're all very familiar with. And we would measure that cat's ketones. There's some discussion about what our threshold for concerns with ketones should be, but the 2.4 millimoles per liter is the number I'm holding tight to. If the ketones are over 2.4, I would think, oh, dang it, you're going to have to be an insulin cat. If the ketones are less than 2.4, then I think an SGLT2 inhibitor is a really viable option. Other things I would factor in are kind of comorbid conditions. And the reason I would think about that is that so far we have essentially zero data on how successful these are in cats with significant comorbidities. And unfortunately, a lot of our diabetics do have significant comorbidities. And so the things I would pay close attention to would be pancreatitis. Does this cat have a history that makes me think he's always zooming in and zooming out of pancreatitis? That might be a concern. And then significant renal compromise would also be a concern. We do have data in cats with some degree of renal compromise taking the SGLT2 inhibitors. And so there's some reassurance that certainly up to potentially a stage 2 CKD cat, it's still a viable choice. But in a cat who was significantly more azotemic than that, I would definitely hesitate. We just don't know if the drug is going to be as effective in a cat who's got decreased renal blood flow associated with CKD. So those would be kind of my two, I don't think you're going to work from a comorbid perspective. But the first thing I would do is measure the ketones, because that to me is a very clear, easy yes or no decision point.
So if I'm understanding you correctly, you're saying if you measure the ketones on your ketone meter and it's greater than 2.4, then you would err on the side of insulin, versus if it's less than that and you don't have obvious evidence of comorbidities, then you would lean more towards the SGLT2 inhibitor.
That's exactly right. So I think of ketones as the body's way of saying, I desperately, urgently need insulin. This is not just about mitigating my hyperglycemia. The ketones, when the ketones are over 2.4, that's the body saying, I need insulin. And so I would default to starting that cat on insulin. Now, if I had a situation in which insulin was absolutely not an option, I've got an owner who looks at me and says, I'm just not doing it. I'm just not doing it. And the cat was happy and eating, then I might have some flexibility as far as my ketone threshold. But otherwise, to me, ketones over 2.4 a presentation is a huge red flag. This cat needs insulin.
I'm so glad you said that, because that was going to be my other question is, what if we have like an otherwise fat and sassy diabetic who looks pretty good, but has that, maybe not much higher than 2.4, but maybe like borderline higher. And we are kind of faced with that owner who says, I just can't do insulin. So it sounds like hold fast to that 2.4. But, if you do run into those situations where you might be talking euthanasia otherwise, then it might be a conversation to have. But be diligent, be aware, because we might not have success with our SGLT2 inhibitors in that case.
Yes, and so that's very well put. And certainly, if the cat is ill, though, if the cat is showing us signs that he is rolling into diabetic ketoacidosis, so not eating, dehydrated, lethargic, then it's not fair to try an SGLT2 and see what happens. I mean, I think in those circumstances, it's insulin, or it's probably more humane to say we're at a point where your cat is too sick for us to even try the SGLT2 inhibitor. It's really not kind at that point. But I've definitely had some colleagues who've said that they're getting more flexible with the cutoffs on the beta hydroxybutyrate on the ketone meter. If the cat is looking fabulous, and for the client, that's it. This is the only treatment I'm prepared to accept, and the cat is sassy and happy, then I've had some colleagues who've kind of bent that rule.
Okay. And I think that's really empowering to say if we do have one where we're looking at a clinical DKA, I think it's empowering to hear you say, at that point, it's reasonable to have the conversation about euthanasia with the owner if they are unwilling to try insulin, because we're not doing any favors for the cat at that point.
Yeah, I agree. It's really not kind to try.
Sure. And that's what we all want, is the good of the animals.
Yes.
Would there be a situation, we kind of talked about, where insulin would be the choice over an SGLT2 inhibitor, like pancreatitis and such? What are some situations where Sunvelgo, where an SGLT2 inhibitor would be more of an ideal choice over insulin?
I think there's definitely some situations in which case that might apply. And so certainly if vets are very comfortable with insulin and are a bit more nervous of making a different approach, I would say there's some patients where, gosh, there's huge advantages to the Sunvelgo. And the first thought I would have is a cat who is on glucocorticoids, and that is probably why the cat has become a diabetic, and potentially you're going to get that cat off of glucocorticoids. Or you have that rare situation of a spontaneously Cushingoid cat that you're then going to be treating and hopefully reversing the hypercortisolism. And the reason why I think Sunvelgo would be great for those cats is you've got a patient where right now they need something to control their blood glucose, but as you get them off of their prednisone, or as the depomedrol wears off, or as their spontaneous Cushing's response to treatment, they might not need anything to control their blood glucose. If you're giving them a dose of insulin, that insulin dose can suddenly become way more than the cat needs. And so that becomes very alarming as far as the risk of hypoglycemia as the insulin resistance fades and the cat either needs less insulin or goes into a full diabetic remission. Because of how the Sunvelgo works, if the cat's pancreas steps up to the plate and is able to maintain euglycemia, the Sunvelgo is harmless. You're not going to risk hypoglycemia. You might be giving a drug the cat doesn't need, but you're not going to have a patient who's really vulnerable to hypoglycemia. So I think that's a really great scenario. The other times I would, and again, this hasn't been looked at specifically, so this is more of us just conceptualizing as far as patients where it could be a really good choice. But the other time I think Sunvelgo would be probably a much more prudent choice is the cat that we think has acromegaly, hypersomatotrophism. So this would be a cat that is bigger than expected and becomes a diabetic. And often with the acromegalic cats, if you just step back for a second and think about it, you can spot them on their physical exam. They have disproportionately big jaws and big feet. And if you look at their teeth, often they get what we call tombstone teeth, where the incisors are separated by little gaps because the teeth are the same size, but the mandible is bigger. And so often on physical exam, you can get a clue. Now, these cats are notoriously insulin resistant. Most of the acromegalics I see come in to see me on 20 units of a potent long-acting insulin twice a day, and the blood sugar is still 400. You're getting absolutely nowhere. They also seem to be relatively unlikely to DKA. I've had one acromegalic DKA, but the flip side is the insulin seems to do not much, but they don't often DKA. So these are cats I think are a great time to reach for Sunvelgo. I think there's a really good chance that we will get the blood sugar back in the reference range, which will make the cat feel better. Cats might be significantly less polyuric polydipsic. They probably will still be very hungry, which is a strong feature of acromegaly because the hunger is from the growth hormone excess. It's not I'm a hungry diabetic, it's I'm a hungry acromegalic. And so they'll probably still be hungry, but you'll get a lower blood sugar, there'll be less PUPD. And so I think you'll actually achieve an awful lot more with an acromegalic with a drug like Sunvelgo than you would by reaching for our traditional feline insulin choices. And then the third category I would think is also a good candidate for Cinvelgo is a hyperthyroid cat because their insulin responsiveness will depend on how well their thyroid disease is being controlled. And so again, with the Cinvelgo on board, you can achieve euglycemia, normalize their blood glucose concentrations, make them feel better, but you haven't got that worry about what's happening to their insulin responsiveness, which can be an issue with a hyperthyroid cat. And so those are scenarios in which case I think Cinvelgo could be a particularly appropriate choice and potentially really significantly superior to a traditional insulin-based approach.
I always forget about acromegaly. Like that's such a good reminder to like you can spot these cats if you're looking for them. You just have to remember to look for them.
They're fascinating. I think what often happens is you might have been seeing the acromegalic cat for years, and he's always been a big cat.
Yeah.
And because often what happens with acromegaly, it certainly models a lot of what happens in people, is the disease actually kicks in teenage boys, and it probably kicks in our acromegalic cats when they're about a year, and so they're just always big. Often, if people have a sibling, often they've got this little cute tiny sibling, but this cat was just always bizarrely huge. And so they just kind of keep on getting bigger and bigger and bigger. And so this isn't usually a perfectly normal cat who was an 8 pounder until he was 8 and then became a 16 pounder. Usually this is a cat that you've laughed at when you saw him for his 3 year wellness visit and thought, he's huge, he's handsome, don't we love him? And then it's just every year, like there's just a bit more cat coming in to see you. So sometimes you do have to step back and think, whoa, this isn't just an entertainingly large cat. This is a cat who's got an endocrine disease, but it does kind of sneak up. And often we don't think about them until they are diabetic or they experience cardiac complications, which is the other big concern with the acromegalics. And so I think keeping your antennae up for those cats is interesting.
Yes, yes. And I think that is like the universal reaction to those cats is like, we love them. They're like, look at this giant cat. He's so cool. But yes, also, like you said, keeping our antenna up, being aware and saying, could there be something else going on here that we should be looking for? I also think this is one of the most fascinating and the most frustrating things about endocrine diseases is exactly like you're illustrating here. They're so intertwined with each other.
Hmm.
And I'm curious because I'm trying to make the pathophysiology work in my head with hyperthyroidism and diabetes. Those I have to say are not comorbidities I see together commonly. Knock on wood. Now I'm going to see five of them back to back. And then the same, you mentioned renal disease, maybe beyond an IRIS stage 2, making them not a candidate for the Cinvelgo. I'm curious how those pathways are kind of intertwined.
So with the CKD cat, the way that the Cinvelgo works, its magic as far as lowering blood glucose is in a healthy cat, each time your heart beats, 20% of cardiac output goes to your kidneys. And so if those kidneys are primed then to dump glucose, you've got a great outspout essentially for glucose. In a CKD cat, like a stage 3 CKD cat, not 20% of every heartbeat goes to kidneys, but less than 2% of every heartbeat goes to kidneys. So renal blood flow is way, way, way turned down when you've got chronic kidney disease. So you just don't have the volume of blood getting to the kidney to then be purged of its glucose. And so the concern we have, and it's not been looked at, is that we just won't get as effective a glucose lowering effect in a CKD cat that's significantly impaired, just because not enough blood runs through the kidney for us to then be able to purge enough glucose to achieve euglycemia. And one of the ways that the SGLT2 inhibitors are so miraculous is by achieving euglycemia, we then let the beta cells start to regain some function. And even if they're not great beta cells, they can be good enough beta cells to make just enough insulin to stop you getting ketotic. But we do need that outspout essentially of the glucose, and a CKD cat just doesn't send enough blood to its kidneys.
Okay, okay, that makes sense. And then can you speak to the hyperthyroidism and diabetes?
Yeah, the hypothyroid is fascinating because that condition touches every single part of physiology, but it does tend to cause insulin resistance. And so it seems as though the insulin you're producing just doesn't have the same effect in a hyperthyroid state. We see the flip side too in hypothyroid dogs. They're often significantly insulin resistant too. And so each time I look at thyroid disease, I just think this is a heck of a lot more clever and complex than just a number is too high or a number is too low. But those cats will sometimes be more complicated diabetics in my experience.
Okay, that's another thing, kind of like we were talking about with acromegaly, just to be aware of, be on the lookout for if you have a hyperthyroid cat that they can present a number of comorbidities that might be a little bit more complicated.
Absolutely.
When I'm thinking of managing diabetics, one strategy where I feel like I've seen make a huge difference, I've had a lot of success, is with dietary therapy. Diabetes can be just a tough disease for owners to manage, especially in a newly diagnosed diabetic. And sometimes when we're introducing dietary therapy, it can just kind of create this other layer of complication. So I'm wondering what your recommendations are on when, if, how to switch diets in a diabetic patient.
I do think that the impact of diet are the shift in our understanding of the ideal diets for diabetic cats has had enormous impact. I am old enough to remember the high carbohydrate, lots of fiber years,
Oh
which with
man.
hindsight, I know was probably, well, it was completely the wrong thing to have done, but you don't know what you don't know. And I'm with you as far as incredibly impressed by the impact we have when we reach for a diabetic diet. So a diet that is actually low in carbs, with most of the calories coming from protein and fats. And the reason those diets are so effective is A, it's what a cat is supposed to be eating. So it makes sense that actually that matches their physiology better. But part of the magic of those diets is those diet ingredients, those macronutrients of protein and fat, trigger the release of incretins from the cat's GI tract. And the incretins are these hormones that are secreted by enterocytes that are tremendously important as far as how we respond to glucose, how much insulin we put out, the health of our pancreas, what the liver is doing as far as releasing glucose. And the one that we're most interested in from a diabetic perspective is GLP-1. If you look at the human diabetic market, the GLP-1 analogs are an enormous part of human diabetes management now, because those hormones are so very, very helpful for beta cell function and glucose homeostasis. When we take a diabetic cat who's on an inexpensive high carb diet, not making that much GLP-1, and we move that cat to a high protein, high fat diet, that cat will make more GLP-1, which will really support beta cell recovery. So I do think those diets are incredibly impactful. Now, I think, though, as a general rule, I wouldn't make an immediate diet switch. Whether I was putting a cat on an SGLT-2 inhibitor or insulin, I tend to think let's just make one major change at a time, rather than having a client who is watching their cat very closely because they've got this new disease. And then the cat is looking at the food and pulling a face, and you don't know, does he not like it or does he not feel well? And so usually I'll say get them on to a couple of weeks on your diabetic treatment plan. So Synvelgo if he's a good candidate, or insulin if he's not a good candidate. Deal with that, and then after a couple of weeks, go ahead and introduce the diabetic style diet. In the clinical trials looking at the two feline approved SGLT2 inhibitors, a diabetic style diet was recommended for one and was not focused on in the other. And so we don't have really clear data on exactly what is the ideal approach for these cats. But most people with an interest in this are saying, get the cat on the Synvelgo for the first couple of weeks, and then when you're cruising, that's a great time to switch them to a diabetic diet. The SGLT2 inhibitors will cause a change in stool consistency in about 50% of cats, usually self-limiting. If you didn't ask the owner, most owners wouldn't mention it, but if you ask them, often they'll say, yeah, the stool is a bit softer when I pick it up. Usually it will sort itself out. But I think it's nice to not have the complication of aunties on a new food in the midst of somebody looking at how their cat is feeling. And so I would say when the cat is cruising, has gone through the first crucial 2 weeks on the Synvelgo, that's a great time to go ahead and introduce the high protein, high fat, carb restricted diabetic style diet.
So another fascinating part when it comes to endocrine disease, the incretins were somewhere in the back of my brain when you said that. My brain said, "Oh yes, I've heard that word before." But how impactful the diet can be, and I would think with using an SGLT2 inhibitor and feeding an appropriate diet, does that have an impact on? We probably don't have data on it on remission in cats.
Oh, feline diabetic remission is such a fascinating topic. And
Yes, it is.
yes, it's like you can't always predict who's going to do it. And everyone's got a cat who's been on insulin for 5 years who went into remission like a
Right.
miracle. And so it's pretty fascinating. But most cats will go into remission if they're going to in about the first 90 days. And so if we've got a cat on insulin, we can tell when they go into remission because their insulin needs will drop. Their blood sugars are suspiciously low. We keep backing off the insulin and then we just slowly drift away. So we've understood about insulin insulin-treated cats going into diabetic remission. And there's kind of three things that we think about as far as supporting remission. First is putting them on a diet that's going to support incretin production, because we know the incretins will help nurse those beta cells back. So diet's a significant part of that. The second component is addressing problems that cause insulin resistance, that mean you have a pancreas that has to work really hard because you are fat, or because you're on steroids, or because you've got chronic gingivitis, stomatitis, your mouth is stinking. So we've understood that we need to address insulin resistance so that we're not asking more of the pancreas than we need to. And then the third part of inducing remission is to achieve euglycemia. And the reason that's important is this phenomenon called glucose toxicity. When that term first appeared, my first reaction was, that's interesting, glucose is poisonous. And I was thinking a blood sugar 500, 600, 700. It makes sense that it's poisonous. You're not supposed to sit with a blood sugar of 500. But certainly from the human perspective, we know that glucose toxicity starts with a blood sugar of 200.
Right.
So once your blood sugar is over 200, you are poisoning certain cells, ironically, particularly vulnerable to being poisoned and shut down and hurt and killed are the beta cells. So every day a cat sits with a blood sugar over 200, we know that they're actually damaging their beta cells. Now, some beta cells just turn off. They're just like, I'm not going to bother to make insulin. If the blood sugar is this high, I'm wasting my time. Some of them actually undergo apoptosis and they're gone. And there was a study that I often talk about when I'm talking about diabetes and remission, because it's one of those papers I read, and it was ages ago, and I still get chills when I read it. And it was a great study where they took two small cohorts of young, healthy cats. These cats were less than 2 years old, purpose-bred cats, so very, very healthy. Half of them were put on a saline infusion for 10 days. The other half had jug calves placed, and they were placed on very high concentrations of dextrose for 10 days. And the dextrose was adjusted so that the cat's blood sugars stayed about 450 to 500 milligrams per deciliter. So these perfectly healthy cats sit there for 10 days in a cage with the researchers tweaking the dextrose infusion to keep that blood glucose over 450, called a glucose clamp. And at the end of 10 days, they biopsied the pancreases of the control cats and the cats who are kept hyperglycemic. And what they found when they stained for insulin production is that the cats who were forced to sit there for just 10 days in a hyperglycemic environment, insulin staining was down by more than 80%.
Wow.
And when they actually counted the beta cells, they had lost 50% of their beta cells. So 10 days of hyperglycemia, 50% of the beta cells were gone. The histopath of the control cats compared to the hyperglycemic cats was shocking. It's just these islets that are depleted. I mean, there's just half the beta cells that there were, and that just took 10 days in cats who had healthy young pancreases. And so that to me was this is what glucose toxicity means. And so every day your new diabetic sits with a blood sugar 320, beta cells are checking out or going underground and turning off. And so when we've got a cat on insulin, if we can get their blood glucose to be well controlled and we address insulin resistance and we fix their diet, that cat may go into diabetic remission. Often it's transient. That can be the frustration that they'll go in and out of remission. We have not looked at remission in cats on Synvelgo because the only way to know if a Synvelgo cat has gone into remission is to take it off the drug.
Right.
And that has not been done yet in any of the studies that have been published. People, I'm sure, are now going to start trying to answer that question. What I would tend to suggest is if you've got a Synvelgo cat who's doing great at the 90-day mark, do you try just taking them off the Synvelgo for a week and see what happens? It can take a couple of days for the glycosuric effect to stop. And so they'll still be piddling out glucose for the first few days after you stop the Synvelgo. But if they are glycosuric day 4, 5, 6, or 7, I would say put them right back on it because they are becoming a diabetic again. Their diabetes has not gone into remission. They need the drug. The other argument, though, is if the cat sits for a few days with a blood sugar of 400 while you test if it needs to come off the Synvelgo, the beta cells that you've carefully nursed back are being hurt. And so there's a little bit of a risk in stopping the drug and seeing if they need it, because if they do become overtly diabetic again, you don't know if the Cinvelgo will be as successful the second time around. And so I don't know, a lot of us have talked about it'd be really interesting to see if these cats go into remission, but to me, it's a little bit of Russian roulette if you take them off the drug if they're doing great, because what if you lose just a few more beta cells and then you've got a cat that actually ultimately now does need insulin to manage its diabetes, and you've really shot yourself in the foot.
Gosh, it is complicated with remission. Because I talked to somebody about this at one point, and we talked about insulin. And we said if this is an insulin dependent cat and they go into remission, I think there's a pretty high percentage that'll then become diabetic again within a year or two. So I think someone was saying, maybe that would be a time where you could consider like a low dose of Cinvelgo, which I know, we're way off label with things like that. But I hadn't really considered it from the standpoint of giving Cinvelgo and not really being able to tell if they're in remission because they are going to be normal glycemic. And so, yeah, it does sound like we're kind of playing with fire there. If they're doing okay and the owner's not having any issue giving the drug, maybe we just leave well enough alone there.
Yes, that would certainly be my thought. If I had a diabetic cat who was happy and doing fabulously on the Cinvelgo and I hit the 90-day point, I would probably just continue with the Cinvelgo. It is so incredibly safe in healthy cats. And also in people, that whole drug class, the SGLT-2 inhibitors, have been shown to be significantly cardioprotective and renoprotective. I just think the next 10 years we're going to learn a ton more about how to slot these drugs into practice. And I think it's just an exciting time in feline diabetes after kind of being stuck with the same old, somewhat challenging treatment options for a very, very long time.
Absolutely. Absolutely. I say that all the time. I'm like, what a time to be a veterinarian. There's just so much happening that we're learning about, and it's so neat. Well, we talked about monitoring ketones when we initially put them on Cinvelgo, when we initially put them on an SGLT2 inhibitor. What is your kind of monitoring protocol for a cat that's newly placed on Cinvelgo, and how is that different for monitoring on insulin?
I do think a lot of the basic principles are going to be very familiar. And so, is the cat eating? Is the cat happy? What's the cat doing as far as body weight? The big difference when we're putting a cat on Cinvelgo is, as you already said, which is really helpful, you've got to have some beta cell function for the Cinvelgo to be a successful treatment. So, you have to be able to make just small amounts of insulin. And an awful lot of cats at the time of diagnosis of diabetes, they can make small amounts of insulin. And it just takes a little bit of insulin to stop ketosis. It takes a lot of insulin to achieve euglycemia. And that's why so many cats do so well on Cinvelgo. But because we don't know when we first met that cat, where is he at as far as residual beta cell function? That's why checking the ketones becomes so important, because for me, ketones really is the hand is waving a red flag at the back saying, I need insulin, I need insulin. And so usually with an insulin treated cat, I'm going to start a pretty conservative insulin plan and then usually see them back in about a week or 2 weeks. I'd have a different approach to a cat I was putting on Cinvelgo. What I would want to do is get them started the day of diagnosis. I don't want to let them sit with a blood sugar of 400 while I order the Cinvelgo. And so I'm urging everybody, you need a bottle of this on the shelf in your practice, because every day with the blood sugar that's too high, it's hurting the pancreas. And so you diagnose that cat, you screen it for ketosis, its BHB is less than the 2.4, you start it immediately on the Cinvelgo. And then what I'd like to do is get that cat back in, ideally about day 2 to 3 again to measure ketones, and then maybe day 7 to measure ketones, and then day 14 to measure ketones. And I would not normally do that in an insulin treated cat. So those first 2 weeks are a bit more intense. But we know from the studies on the SGLT2 inhibitors in cats that most cats who are going to get DKA because they really don't have enough beta cells that are able to do what needs to be done, those cats will manifest in the first 2 weeks. That's the period where we're trying to say, okay, pancreas, show us what you can do. And if the BHB levels move up, if the cat goes over 2.4 millimoles per liter, that's a huge flag that it's not got enough functional beta cell mass at that present moment to even prevent ketosis. And so that cat would be then transitioned onto insulin.
At those monitoring appointments at 2 to 3 days, 7 days, and 14 days, we're checking BHB. That's our primary monitoring parameter? If our BHB is good, then we, say you're good to go and keep going at the same dose. And then at that point, are we pretty well in the clear at if they're good at 14 days?
So generally speaking, yes, unless something happens like the cat does get pancreatitis or something, he could DKA at any point in time. But usually, if they're going to DKA because the pancreas is just not up to the job and they're just not a Cinvelgo cat, it's usually going to happen in the first 2 weeks. And so, rather than measuring blood glucose, actually the most important thing to measure is the BHB on those day 2 to 3, day 7, day 14 visits. I would say, as far as seeing if the drug is able to achieve euglycemia, day 30 is kind of my cut for how is your blood sugar doing. So day 30 is a great time to do a spot check on the glucose. And if the glucose is normal, you're fabulous. If the glucose is a little bit high, you can do a fructosamine and see where are we at more on a more chronic basis, because there's some cats where their BHBs are still fine, but their blood sugar is still 350 and it's sustained, and their fructosamine is still 520, and they just haven't been able to respond effectively to the drug. It's not all that common, but day 30 would be my kind of cutoff for saying, I don't think this really isn't a great fit for you, and maybe making a transition to insulin at that point. But in those first few visits in the first 2 weeks, you can measure a blood glucose for grins, and there's a really good chance it will be euglycemic, but it's the ketones that really matter.
Okay, and that's good to know that if they're not normal glycemic, of course, we're still getting that glucose toxicity and we're getting damage. So we may want to think about making that switch sooner rather than later. And I know with our insulin dependent diabetics, once I feel like they're cruising and we've got a good dose, a lot of times I'll check them every 6 months, ideally. Sometimes owners will only let me do it every 12 months if their cat's doing perfectly otherwise. How often do you check a BHB on a cat where you say, okay, you're good, your glucose, your normal glycemic, your BHB levels are good, you're doing great, 30 days, 90 days, everything looks good. After that 90-day mark, how often are you checking them?
Most of the recommendations right now say probably get them back in again about 90 days.
Okay.
And certainly even for my insulin treated cats, I usually like to cast an eye on them every 90 days, partly because they're older. I want to keep a really close eye on their body weight because that's often a clue that they're not as well controlled as I would like. So I would tend to think in terms of an outpatient visit. They can eat and have their meds that morning. They come in, you can do a physical exam, you can chat to the owner, you can draw a drop of blood, do a blood sugar and a ketone. Those numbers are sweet. Cat is good to go. But I probably would still default to trying to get them back in every 90 days or so just to keep a tab on them.
I like it. I like it. Yes, and I would agree. Even with our insulin cats, we would like to have them in every 90 days. Just thinking from a GP perspective, it's an easier sell to owners to do this on an outpatient appointment, to say just come in and go versus, let's do a freestyle Libre, let's do a glucose curve with a drop-off appointment and things like that, to say let's just come in and check a BHB, weigh them, we'll see how things are going and then send you home.
Yep, very, very low-key outpatient. Much, much, much simpler from the owner's perspective, and I think much less stressful for the cat than a day in the hospital. Again, 2.4 is kind of my rule. If I had a cat that was happy and eating and the BHB was 2.8 at the day 7 recheck, but the cat was still looking fabulous, I would have to have a real heart-to-heart with the owner, as far as my instinct, to be honest, would still be to transition that cat to insulin. If the client had said to me, no, then I would ride it out. And some colleagues have said that they have ridden out some BHB in the blood that was higher than they liked, and the cats have then moved their BHB down as they get more pancreatic cell recovery because we've achieved euglycemia. But I do think you have to have a real heart-to-heart with the owner, because if that cat becomes a true diabetic ketoacidotic patient, certainly in our practice, that is a many thousands of dollars disease, several days in the hospital. And so I think you've got to be very, very clear with owners. If the BHBs are unsatisfactory day 7, you've got to be really clear as far as there's significant risk to the cat and to your pocketbook of holding tight to the SGLT-2 inhibitor versus transitioning to insulin.
Sure, sure. And I think that's important, like you said, to really emphasize that to the owner of, I can appreciate that you want this once daily oral as opposed to having to do insulin therapy, because, who wouldn't want that? But we're taking a big risk, and this is what we've got on the line here if we don't go ahead and switch to insulin.
Indeed. And that's why I'm such a believer in every clinic getting hold of a ketone meter. I mean, they're less than $50 on Amazon. You can get one in 24 hours. And it's interesting, once you get a ketone meter in the clinic, you'll find that you're measuring ketones on many of your insulin-treated diabetics just to get a feel for how they're doing. And now we'll do much more blood BHB monitoring for our DKAs than we used to. Because if you actually look, there's been some lovely papers that have compared blood measurements of beta hydroxybutyrate versus using a urine dipstick.
Yeah.
And in the olden days where you were going to get insulin, it wasn't all that important to be that attentive to what your blood ketone levels were. If you were sick, you got IV insulin. If you were eating unhappy, you got sub-Q insulin. And so it was a little bit of an academic concern as far as really knowing how high your ketone levels were. But now, because of how the SGLT-2 inhibitors work, it really does matter that we know pretty precisely what your blood ketone levels are. And the primary ketone in the cat is beta hydroxybutyrate, BHB. When we do a dipstick in the urine, that dipstick primarily picks up acetoacetate, maybe a little bit of acetone too, does not pick up beta hydroxybutyrate. And so when your BHB levels are getting really high, there's a pretty good chance you've got acetoacetate in your urine in concentrations that the dipstick will pick up. But it is absolutely apples to oranges. We're not measuring the same chemical. What we're measuring in the urine is much less metabolically important. So I really think we need to get away from the urine dipstick idea. And then a crisis, you can put serum or plasma onto the dipstick, and that is probably superior to putting urine on the dipstick. But again, we're not measuring the primary ketone body, we're measuring a secondary ketone body. And so anybody says, I think I'm just going to put the serum or the plasma on the dipstick, I'm thinking, yeah, you can, but just get a handheld ketone meter. Thanks to all these kind of ketogenic diets in people, the meters are out there, they're inexpensive, they're incredibly easy to use. And that just gives us a number that we can actually track on those early visits and say, you're moving up, I'm a bit worried, come back a bit sooner, you're holding steady, you're moving down. We actually get a really hard and useful data point.
Absolutely. I actually had that conversation with a colleague the other day who she works in emergency, and she was like, these are driving me crazy because they're euglycemic and all this. And I said, well, get a ketone meter and check them. And she was like, well, I don't even know, what those look like. And I think it was you who told me, where I said, go on Amazon, you can get one really readily and just have one in the clinic. And so I don't know if she did or not, but we were just having that conversation about how easy it is to get a hold of these meters and to monitor beta hydroxybutyrate. And I'm glad you said that, because that was a question I had about urine versus blood monitoring for ketones. Am I understanding your answer correctly that BHB is the primary ketone body in cats? So if we're putting urine or serum on a dipstick and we're measuring acetoacetate as a secondary ketone body, we might not see the same sorts of elevations as quickly and be able to react as quickly as if we were directly measuring the BHB in the blood?
That's exactly right, Jill. It'll tend that there can be a significant delay before you get a change using the dipstick technology, even if a cat's BHB is kind of hit a bit of an eye-watering level. And so there was one really nice study where they looked at urine on a dipstick, and I think it was plasma on a dipstick, and then they measured BHB in the blood. And by the time the cats had a BHB that was strongly suggestive of DKA, something like only a third of the cats had the same reaction on using the dipstick technology. And so to me, that was a really nice example of it is so crude and so out of date, and to be honest, really an inappropriate way for us to be even thinking about assessing patients for ketosis. And I think when the SGLT2 inhibitors first came out and people said you have to get a ketone meter, everyone's expecting some huge investment in some giant thing that would sit under a dust cover and take up space on the counter. I don't think people understood that these handheld devices are just like teeny tiny glucometers and just as easy to use. And so hopefully the message is getting out that for $50, you have this machine in your clinic that will give you a really, really reliable number. It'll pay for itself after 2 uses. I mean, it's just an incredibly useful investment. I mean, the scenario I think it's most important is really important for emergency clinics to have this. And so if anybody listening to this is an emergency vet or does relief at an emergency clinic, every EC needs to have a ketone meter. And the reason I keep stressing that is that cats on SGLT2 inhibitors will get this condition called euglycemic DKA. And when somebody first used that term with me, I kind of put my head on one side and said, that doesn't make sense, because one of the features of DKA is hyperglycemia. And that's true if you're on insulin or you're untreated. But you can have scenarios, and it befuddled human ER physicians when the SGLT2 inhibitors first became widely used in people with type 2 diabetes, because walking into the ER vomiting and dehydrated and feeling horrible is this person who's a type 2 diabetic on an SGLT2 inhibitor, and their blood sugar is 92. And so the ER doc would think, oh, you've probably got gallstones or appendicitis or pancreatitis. They would look for all these other reasons for feeling bad. Because the blood sugar was normal, they wouldn't think about DKA. But you can have a patient where the drug is effective enough to lower blood glucose, but the pancreas is not able to put out just that little teaspoon of insulin you need to prevent ketosis. And so these patients are ketotic, they are acidotic, they are clinically ill, but the blood sugar is 90. And I worry about cats on SGLT2 inhibitors hitting an emergency room and seeing a doctor who's maybe not thought about feline diabetes a lot, because they don't usually treat them unless they're in DKA. And that's a standard traditional hyperglycemic DKA, versus euglycemic DKA is the classic form that we see in people and cats on SGLT2 inhibitors. And the clue is you measure their blood ketones and their BHB is 7. And like, okay, he's on an SGLT2 inhibitor, his BHB is 7, he feels bad. Yes, the blood sugar is 90, but this cat is desperate for insulin and is a euglycemic DKA.
That was such a good, thorough explanation of, monitoring for DKA in these patients, because I think that is one of the scary parts when we think about using an SGLT2 inhibitor, if we've not used one before, to say, oh, well, now there's this new condition I need to be on the lookout for. But, really emphasis on how cheap and easy it is to have that ketone meter handy. And you can know right away, okay, we need to get this cat off of an SGLT2 inhibitor and onto insulin and treat them just like we would any other DKA.
Yes, indeed. The tricky part is our traditional DKAs, we start insulin and the blood sugar starts to move down, and then we add some dextrose to their fluids. The difference with the euglycemic DKA is they need insulin immediately, but they also need large amounts of dextrose immediately.
Right.
And so there's been some kind of recipes pulled together to give some outlines. And actually, I wrote a review paper recently for the Journal of Veterinary Pharmacology and Therapeutics, and it's open access. Dr. Berend and I, who's just brilliant, came up with this is our recipe for euglycemic DKA, at least to give you a place to start as far as when they come in the door, bolus them with this much dextrose, start this much insulin CRI with this much dextrose running at the same time. And so we've come up with a recipe. Like any recipe, it's a place to start and it needs to be adjusted based on what the patient is telling you. But I wanted some resources for a busy ER doc to think, how much dex, what do I do? And so at least that's a recipe that we kind of calculated all the complex mathematics on relationships between insulin and glucose and how much glucose is still being lost in the urine as a result of the drug until that wears off. And so we've come up with a plan, and I'm sure it's not a perfect plan, and I'm sure 5 years from now there'll be really elegantly designed and proved recipes out there. But when I first heard about euglycemic DKA, I sketched out a recipe for the ER docs in my hospital here, because I didn't want a brand new intern to be faced at 2 a.m. by trying to decide what they were supposed to do for a condition they hadn't even been taught about in school, and therefore kind of had no frame of reference. And so we pulled together a recipe that I think is at least a safe starting point.
That's great. That's what I'm going to do immediately after we get done with this recording, is go find that recipe, because like you mentioned, we need that in ERs, and absolutely, I'm sure it will continue to evolve and be refined over time. But what a great starting place, because also, like we've touched on earlier, DKA can be really intense and it can be really expensive. So, I know sometimes if we get, that 8 a.m. appointment and we're like, that's the DKA, we will try even in GP to say, well, can we run them on insulin and dextrose throughout the day and then transfer after that to try to save the owner a little bit of money. So having access to those recipes and saying this is a good starting place, and then monitor and adjust throughout the day, that's wonderful to know that's out there as a resource.
Well, I'm hoping it's going to be helpful, because I didn't want an intern phoning me at 2 a.m. to ask this question, and me trying to get that piece of paper and do complicated insulin kinetics mathematics, from a deep sleep. And so, yes, I'm sure that smarter brains than I and the critical care world will tweak it. But I think we needed something out there that was at least a place to start.
Absolutely. Absolutely. Yeah. And that's good motivation to say, well, now my phone won't ring at 2 in the morning because they have a starting place. Well, Dr. Cook, as always, whenever we talk, I learn so much from our conversations. I feel like you just bring this practicality to the conversation where I walk away going, oh, okay, I know what to do. I can use this information and really go out and benefit my patients. So thank you so much for joining me. Are there any final thoughts you want to share?
Well, thanks for having me. And I would just encourage everybody who's a little bit nervous of reaching for this brand new drug class to read some of the resources that are out there and have a bottle on the shelf, because walking in the door probably tomorrow will be the perfect candidate owned by some little old lady with arthritis who absolutely cannot possibly give an insulin injection. And so I'm just encouraging everybody to invest in one bottle to sit on the shelf so you can help those cats where it's going to be the perfect choice.
Absolutely. Absolutely. It's such good advice because it seems like, we can really benefit a lot of cats out there.
Wonderful. Thanks so much for having me.
Dr. Cook, it is always a pleasure. Thank you so much for joining me on this podcast. Big thank you to Boehringer Ingelheim Animal Health for making this episode possible. And I hope everyone who tuned in, thank you for joining us. I hope you learned a lot from this episode. If you enjoyed this episode, please leave us a 5-star review wherever you get your podcasts to help other veterinary professionals like you find this podcast and other great content we try to put out there. For more episodes like this, click on the Education tab on the Vetfolio website. As always, we'd love to hear your input on this talk as well as ideas for topics you'd like to hear from us in the future. Feel free to reach out to me at dvm@vetfolio.com. You can also visit my Facebook page at Dr. Cassie DVM, and you can find me on LinkedIn. And remember, if one animal is better off because of you today, it's a great day. Important safety information. Cinvelgo, velagliflozin oral solution, is indicated to improve glycemic control in otherwise healthy cats with diabetes mellitus not previously treated with insulin. Before using this product, it's important to read the entire product insert, including the boxed warning of diabetic ketoacidosis or euglycemic diabetic ketoacidosis, both of which may result in death. Development of these conditions should be treated promptly, including insulin administration and discontinuation of Cinvelgo. Do not use Cinvelgo in cats with diabetes mellitus who have previously been treated with insulin, who are receiving insulin, or in cats with insulin-dependent diabetes mellitus. The use of Cinvelgo in cats with insulin-dependent diabetes mellitus, or the withdrawal of insulin and the initiation of Cinvelgo, is associated with an increased risk of diabetic ketoacidosis or euglycemic diabetic ketoacidosis and death. Sudden onset of hyperexia or anorexia, lethargy, dehydration, or weight loss in cats receiving Cinvelgo should prompt immediate discontinuation of Cinvelgo and assessment for diabetic ketoacidosis, regardless of blood glucose level. Cinvelgo should not be initiated in cats with ketonuria, ketonemia, pancreatitis, anorexia, dehydration, or lethargy at the time of diagnosis of diabetes mellitus, as it may indicate the presence of other concurrent diseases and increase the risk of diabetic ketoacidosis. Keep Cinvelgo in a secure location out of reach of children, dogs, cats, and other animals to avoid accidental ingestion or overdose. For full prescribing information, visit cinvelgoclinic.com. That's SENVELGO clinic.com.